Imagine the control center of your entire body, your brain, suddenly under attack, inflamed, kind of struggling to send the right signals.
Yeah.
What happens when the brain itself becomes the battlefield? It's a really serious, urgent situation.
It is. It leads to rapid neurological changes, can cause profound disruption to function, and, well, it's often life-threatening if not addressed really quickly.
Absolutely. So for this deep dive, we're zeroing in on that exact scenario, encephalitis. And we've got some incredibly detailed revision notes here, which were generously shared by one of you listening. And our mission, really, is to take this complex info and, make it stick. We want to cut through the detail, give you that high-yield understanding, basically. A shortcut to being well-informed on what encephalitis is, what drives it, how we figure it out, and critically, how it's managed.
Right. Think of this as us guiding you through the essential facts you need to know, and framing it specifically, hopefully, to help you consolidate and remember it all.
Exactly. So we'll navigate through the material using a logical flow. We'll kick off with the fundamental question. What do we mean by encephalitis?
Then we'll explore the, well, surprisingly broad range of things that can trigger this inflammation, focusing maybe on the most common culprits.
Yeah, and we'll look at who might be more susceptible, touch on what's actually going wrong inside the brain.
And importantly, discuss what else it could look like, those crucial differential diagnoses, because that's key, isn't it?
Oh, absolutely. Recognizing it amongst other possibilities is vital. We'll also look at how common it is, dive into the specific signs and symptoms you'd be looking for clinically.
Explain the essential investigations doctors rely on, cover the critical aspects of treatment, and finally, discuss the potential outcomes, the challenges patients might face afterwards.
Our goal is really to pull out the facts that matter most, link them together, and structure them in a way that's hopefully easier to recall, especially if you're using this for revision.
Okay, so let's start right at the beginning then. Based on the source material we have, what's the core definition of encephalitis?
It's defined simply and clearly. Inflammation of the brain parenchyma itself.
The brain tissue.
Right, the brain tissue.
And that simplicity, it kind of belies the seriousness, doesn't it? This inflammation isn't just, a bit of swelling. It directly impairs brain function. That leads to the significant neurological issues we see.
And while the definition is straightforward, the causes, well, they're anything but. The material immediately highlights that it can be triggered by infectious agents, viruses, bacteria, fungi, or even by the body's own immune system, mistakenly attacking the brain, what we call autoimmune encephalitis.
Yeah, and what's striking here is the emphasis on viral causes being particularly common, with herpes simplex virus type 1, HSV1, specifically called out as a frequent cause, especially here in the UK.
Right.
But yes, that rise in recognizing autoimmune types like NMDA, our antibody encephalitis mentioned here, that's really changing how we think about some cases.
There's a quick but important clarification from the source, too, about meningoencephalitis.
Ah, yes.
That means you've got inflammation involving both the brain and the meninges, those protective layers around the brain, and spinal cord. It's sort of a combined picture.
Right, both structures involved. And it's worth noting these conditions are listed as notifiable diseases. Cases need reporting.
Good point. Okay, so digging deeper into the potential invaders, the etiology, the notes, really flesh out the viral list beyond HSV.
There's VZV, varicella zoster virus, enteroviruses, arboviruses transmitted by insects like West Nile virus, quite a few common ones.
They even mention HIV-associated causes, often linked with opportunistic infections like toxoplasmosis.
Yeah. And a specific high-yield detail for HSV, which is useful. Well, HSV1 is the usual culprit in adults and older kids.
HSV2 is more common in very young babies, neonates.
Right. That's a key distinction.
The other viral causes listed cover a huge range: CMV, adenovirus, influenza, polio, rubella, rabies, even tick-borne encephalitis virus, which is relevant in parts of Europe.
Bacterial causes are noted as much rarer as direct invaders of the brain tissue itself, though bacteria are, of course, common causes of meningitis, which can sometimes spread.
Yeah, the source lists possibilities like strep pneumo or Neisseria meningitis, but also things like TB, Mycoplasma, Listeria, Lyme disease, Legionella, neurosyphilis. It's quite broad, even if rarer.
And fungal invaders aren't missed, like Cryptococcus or Candida, often in immunocompromised folks.
Right. And parasites, too, like toxoplasmosis and that terrifying one from contaminated water, Naegleria fowleri, causing primary amoebic meningoencephalitis.
So the sheer breadth of potential causes is one of the first major challenges, in diagnosing encephalitis.
Definitely. But as the notes highlight, we also need to consider other causes, making sure we don't forget those crucial autoimmune types where the immune system targets the brain, and things like rickettsial infections.
Given this vast list of potential triggers, are some people more likely to get it? The material points to several risk factors.
Yeah, age is definitely one. While it can strike anyone, certain viruses target specific age groups, and encephalitis overall tends to be more frequent and maybe more severe in the very young and the elderly.
And anyone with a weakened immune system, right? Whether from conditions like HIV/AIDS or medical treatments causing immunosuppression, they're also at higher risk.
Lack of vaccination against preventable causes, that's an obvious one. Where you live or travel matters too. Risk increases in areas where mosquito or tick-borne viruses are common.
True. And sometimes it can sort of follow on the heels of another viral illness. Post-infectious, almost.
Okay, shifting gears to what's actually happening inside the brain, the pathophysiology. The general mechanism is described as the body's immune response to the trigger.
Yeah, so whether it's fighting a virus or it's misdirected in autoimmunity, this response causes inflammation and damage to the brain tissue itself. And that is what leads to the neurological signs and symptoms we see.
For HSV1 specifically, the notes add a really key piece of information. It tends to affect the temporal and frontal lobes, apparently accounting for a large percentage of adult cases. This localization is incredibly important clinically, isn't it?
Absolutely. Because those areas of the brain control specific functions like memory, emotion, language, it gives us clues about the cause based on the symptoms.
Now, because the symptoms can be quite broad, things like headache, confusion, fever, what else could look similar? The section on differential diagnosis is vital for clinicians.
Hugely important. First on the list is meningitis, obviously. Inflammation of the meninges, not the brain tissue itself, though you can get the mix, meningoencephalitis.
Right, but separating pure meningitis is important for diagnosis and treatment. Stroke is another crucial differential, sudden neurological deficits.
Yeah, and brain tumors can present with similar, maybe more progressive symptoms.
Other systemic infections, Lyme disease or TB, they can have neurological features.
And remember those autoimmune causes we mentioned. Other autoimmune conditions like MS or lupus, SLE, can sometimes mimic encephalitis symptoms too.
The notes list even more possibilities. Inflammatory conditions like Behçet's disease, rare reaction post-vaccination, neurosyphilis.
Space-occupying lesions like abscesses, and even certain cancers affecting the nervous system like leukemia and lymphoma. It's a really broad list to consider.
Definitely need to keep an open mind.
So to help navigate that list and differentiate, the source gives us some key diagnostic clues. Always ask about travel history, contact with animals, insect bites.
A patient's immune status, their occupation.
Exactly. And here are two specific associations highlighted that are great memory hooks. Chickenpox encephalitis often affects the cerebellum.
So think balance and coordination issues.
Right, precisely.
Huh.
And herpes simplex encephalitis is linked with temporal lobe epilepsy, those specific types of seizures originating in the temporal lobe.
Useful links. Okay, moving on to how common this is, the epidemiology section gives estimates for the UK.
Yeah, it's thought to occur in about, 1.5 to 7 people per 100,000 population each year, with variations by region.
And confirming the risk factors, it's highlighted again that incidence and severity tend to be higher in children and older adults.
So while not incredibly common overall, it's certainly not rare, and the potential severity makes it really high stakes.
Absolutely. So putting it all together, what would make you suspect someone might have encephalitis? The clinical features section lists the signs and symptoms you'd be looking for.
The absolute core features, repeatedly emphasized, are fever, headache, and altered mental status.
Right, that confusion, disorientation, changes in personality or behavior.
Exactly. Add seizures to that list as a very common and significant symptom.
Okay. Other signs include focal neurological deficits, so problems in specific areas like weakness or sensory loss.
Behavioral changes, nausea, vomiting, sensitivity to light, phophobia. And sometimes, though maybe more typical in meningitis, a stiff neck. A rash can also be present, depending on the cause.
To help with recall, the notes specify some key features to really lock into memory. Fever, headache, psychiatric symptoms, seizures, vomiting, and focal signs like aphasia, difficulty with language.
And a crucial point for HSV specifically, the notes clarify that peripheral cold sores, on the lips or face,
Are not related to or predictive of having HSV encephalitis in the brain. That's important. Don't let the absence of a cold sore make you dismiss the possibility.
Exactly. Don't be falsely reassured.
The typical progression is also described. It might start quite innocuously, maybe flu-like symptoms or just a headache.
But then rapidly worsen, progressing to confusion, significant changes in consciousness, seizures, potentially coma. Signs of rising pressure inside the skull might develop too.
And survivors may experience long-term issues like ongoing epilepsy, persistent focal deficits, or cognitive problems. It can leave its mark.
The notes also briefly touch on a much more severe disseminated form of HSV infection, which has a very poor prognosis. Presents with systemic issues like shock, jaundice, bleeding problems.
Specific rash called purpura, and sometimes a more widespread vesicular rash. That sounds like a really dire sign.
It is. Okay, so the clinical suspicion is high based on these features. What steps do doctors take to figure out exactly what's going on and confirm the diagnosis? Investigations are key.
First and foremost, lumbar puncture is listed for CSF analysis.
Taking a sample of the cerebrospinal fluid? Yeah. What are we looking for in that fluid?
We analyze the cell count, the notes mentioned, typically finding a lymphocytosis, an increase in lymphocytes, which often points towards a viral cause.
Right. We also measure protein and glucose levels, and crucially, test directly for infectious agents.
Blood tests are standard too, looking at blood counts, markers of inflammation.
And specific tests like PCR polymerase chain reaction to detect viral DNA or RNA, or serology tests looking for antibodies.
Imaging is also vital. MRI of the brain is preferred because it gives such detailed pictures.
Though CT can be used, often initially, maybe to rule out other big things like bleeds or large tumors quickly.
Yeah, and the notes point out that while imaging may show specific changes consistent with inflammation, especially in the temporal lobes for HSV,
it can also be normal. You can't completely rule out encephalitis based on a normal scan alone, especially early on.
Good point. And finally, EEG electroencephalography, measuring the brain's electrical activity.
Right. This can reveal abnormal patterns. A specific finding the notes mention for HSV, though it's not always present, is the presence of lateralized periodic discharges at 2 Hz.
A particular type of electrical wave pattern on one side, about twice a second.
Yeah. Putting all these investigation results together is how a diagnosis is often reached.
Which leads us directly to management. Given the potential severity and, the speed of deterioration, the initial steps are critical.
Yes, immediate hospitalization is essential, especially for significant neurological symptoms. And this next point from the notes is just absolutely paramount. Immediate intravenous acyclovir for suspected cases.
You do not wait.
You do not wait for confirmation if you think it might be HSV encephalitis because of how quickly it can be fatal. Start the treatment first. Ask questions later, almost.
Right. Beyond the specific treatment for the cause, primary management is supportive care. Monitoring vital signs closely, ensuring the patient is hydrated, nourished.
Managing complications like fever or seizures as they arise, just keeping things stable.
Then, once a cause is identified, or based on that initial suspicion, specific therapy is given antiviral medication like acyclovir or appropriate antibiotics if a bacterial cause is found.
And for autoimmune types, different treatments are needed, often involving immunomodulatory therapies to sort of dampen down that misguided immune response.
And throughout, symptomatic treatment for fever, pain, seizures, that's crucial for comfort and safety.
The notes strongly reiterate the point about prompt acyclovir for suspected HSV encephalitis, explicitly stating that prognosis improves significantly if treatment is started before the patient goes into a coma.
That timing seems so critical. They also mention the role of steroids in HSE is currently considered uncertain, based on the evidence reviewed in the source.
Yeah, that's an ongoing discussion. Managing fluids needs careful attention, too, to avoid worsening brain swelling.
Other treatments might include medications to stop seizures, sedatives if needed, ICU support for the really severely ill patients,
broad-spectrum antibiotics sometimes to cover for potential secondary bacterial infections, and specific antifungals like amphotericin if, say, amoebic encephalitis is diagnosed.
And finally, rehabilitation, often needed in the recovery phase, involving physio, occupational therapy, speech therapy.
To help patients regain function lost due to neurological or cognitive deficits, the journey doesn't end at discharge.
Definitely not. So looking at the potential future prognosis and complications, the notes make it clear the outlook varies tremendously.
Hugely. Depends on what caused it, how severe it was initially, and crucially, how quickly treatment was started. Outcomes can range from a full recovery to really significant long-term problems.
It's associated with high morbidity, meaning long-term illness or disability, and significant mortality.
And this is where the stark reality hits home. A detail from the source that really underlines the urgency. Untreated herpes simplex encephalitis is often fatal within just 7 to 14 days.
Wow, just 1 to 2 weeks.
Yeah, that's how quickly this can escalate without intervention.
Factors linked to a worse outcome include increasing age, being immunocompromised.
Presenting in a coma, needing breathing support like ventilation, and low platelet counts, all signs of severe illness.
Complications can affect various systems. Physiological issues like hormone imbalances, blood clotting problems, even cardiac or respiratory arrest.
And a significant long-term complication is developing epilepsy. That can be life-changing.
And the impact on the brain itself can lead to neuropsychiatric issues, ranging from, mild cognitive impairments to severe ones, changes in personality, or significant behavioral and emotional problems.
Physical complications, too, can range from minor balance issues to severe and permanent neurological deficits.
The material concludes by just touching on prevention strategies.
Yeah, things like vaccination, where available for specific types, measures to control disease vectors like mosquitoes and ticks.
And important notes on preventing neonatal HSV encephalitis, suggesting considering C-section for mothers with active genital herpes and potentially prophylactic aciclovir for the baby.
Right, some practical preventative steps.
Okay, that was a thorough exploration of encephalitis, guided by these really detailed notes. We certainly covered a lot of ground.
We have. So if we were to pull out the absolute core high-yield takeaways from this deep dive, what would they be?
Well, first, remember encephalitis is brain inflammation. Simple definition, but
with a surprisingly broad list of potential causes: viruses, bacteria, fungi, and importantly, those autoimmune processes.
Yes, and while the list is long, these notes really emphasize viral causes, particularly HSV-1 in the UK is very common, but also highlighting the growing importance of recognizing autoimmune types.
Diagnosing it isn't just one test. It typically requires combining the clinical picture, CSF analysis from a lumbar puncture, imaging like MRI, and specific blood tests, including PCR.
And the key to management, especially acutely, is supportive care plus prompt, specific treatment if a cause is identified or strongly suspected.
And that means starting intravenous aciclovir immediately for suspected HSV. Cannot stress that enough.
Absolutely. The notes repeatedly highlight that for conditions like HSE, prognosis improves significantly with timely treatment, especially before the patient reaches a state of coma. That pre-coma window seems vital.
It really does. And finally, just understanding that the outcomes are highly variable, from complete recovery to potentially severe long-term physical and neuropsychiatric complications.
So why is grasping all these specific points from the source so valuable for you listening?
Well, because recognizing the early, often non-specific signs of encephalitis, appreciating the need for rapid investigation when you suspect it, and understanding the absolutely critical importance of starting treatment quickly even before you have a definitive diagnosis that can fundamentally alter the patient's trajectory.
Yeah, think back to that detail from the source. Untreated herpes simplex encephalitis, often fatal within 7 to 14 days.
Yet prompt aciclovir dramatically improves survival and reduces morbidity.
The difference between a devastating, potentially fatal outcome and potential recovery can literally hinge on recognizing those subtle early signs and acting with extreme urgency.
It's a powerful example, isn't it, of how clinical acumen and just rapid action can have a monumental impact.
Hopefully going through these notes like this has helped clarify the key points and made them more memorable for you, especially if you're consolidating this knowledge for revision.
Keep testing yourself and linking these facts together. That's how it sticks.
And for further study and practice on topics like this, remember to check out the resources at passthemsra.com and freemsra.com.
Yeah, they offer great tools to help you dive even deeper and really solidify your understanding.